Good morning, good afternoon, and good evening. Thank you for attending Ifso Journal Club today. My name is Alan Saber. I'm the Chief of Bariatric and Metabolic Surgery at Newark, West Israel. In New Jersey, I'll be the moderator of Ifso Journal Club today. A very important topic. We're talking about Ifso position statement on one anastomosis gastric bypass and update. I would like to thank Manuela Mazralla, our Ifso Chief Operating Officer, for arranging this event. We have two distinguished experts on one anastomosis gastric bypass. The presenter, Dr. Mauricio De Luca. Dr. De Luca is a professor of surgery, director of general and metabolic surgery, Center of Excellence, Rovigio Hospital in Italy, vice president of Italian Society of Bariatric and Metabolic Surgery. On the panel, we have Dr. Jean-Marc Chevalier, MD, PhD, professor of surgery, University Hospital Paris. Dr. Chevalier devoted more than 15 years of his academic career studying the scientific basis of one anastomosis gastric bypass. Two things I would like to mention to the audience. Please put your question on the chat, and the webinar will be of today will be recorded. Will be available on Ifso website and also on Ifso YouTube channel. Without further ado, let's get started. Manuela, can you please put the multiple choice question, the poll? So the first question, within the next 5 years, how you expect one anastomosis gastric bypass will represent in your practice? Please select one. Will significantly increase, will slightly increase, will be the same, will decrease, I will stop doing it. Please vote. Well, it seemed to be 1/3. It said significantly increase and 40% slightly increase. So we are in good shape. So a lot of interest in the one anastomosis gastric bypass. Next will be Dr. De Luca presentation. Manuela, can you please put the Dr. De Luca presentation?
Thank you, Alan, and thank you, Ifso, for your kind invitation in this presentation. I want to thank you, first of all, for the possibility to give me the Ifso position statement writing. So this is an update to 2021 of the first Ifso position statement 2018. So I go ahead with my presentation. First of all, I want to consider my case mix disclosure of my last 5 years activity, where you can see I performed 38% of the cases ORGB, sleeve gastrectomy 33%, Roux-en-Y gastric bypass 22%. But what I want to point out is that in the last 2 years, in our institute, we had 22% of revisional surgery. So we are going to talk of our previous position statement 2018 and our updated position statement 2021. First of all, an overview of the different study design. As you can see, this is a very famous pyramid, and we can see that in the lowest part of the pyramid, we have case report or case series. Then, going up in the pyramid, we have observational studies like case control studies, cohort studies, and randomized control trial. But going in the upper part of the pyramid, we have meta-analysis and systematic review. Why I am showing this pyramid? I am showing it in order to remember that what we are talking about is a systematic review. Systematic review and meta-analysis are epidemiological types of studies which don't provide new data but have a great importance, as we have seen in the pyramids. They both allow to have a summary picture of the scientific evidence present on a particular topic, and they express the state of art of scientific research in each sector, conducted usually by experts in that specific field. Systematic review is a common type of research used in the assessment of literature and studies, which addresses a particular related issues. It is considered in order to summarize, but better to collect the results, and can provide vital information about the effectiveness of an operation. Meta-analysis is a study design which is a powerful research method compared with systematic review, which collects. In this case, we have an analysis and comparison of the results of several similar studies. It's a rigorous meta-analysis is a great approach to evidence-based medicine. What about our previous position statement? It was issued by the Ifso MGB ORGB task force and approved by the Ifso scientific committee and the Ifso executive board. It was based on the clinical knowledge, expert opinion, and published peer-reviewed scientific evidence. First of all, a consideration between the differences between MGB and ORGB. MGB consists of a lesser curvature-based long-sleeved gastric pouch starting 2-3 centimeters below the level of the crow's foot. And then it performed an anticolic 3 to 5 centimeter wide anastomosis with the jejunum. The measurement of jejunum was 118 centimeters to 220 centimeters from the triceps ligament. In the super obese, 215 centimeters and more. In the elderly or vegetarians, 118 centimeters to 200 centimeters. And in overweight or class 1 obesity with type 2 diabetes, 150 centimeters. This is MGB. What about ORGB? In 2002, Carbaco and Caballero proposed a technical variation of this procedure. First of all, in order to reduce the gastroesophageal bile reflux. They called it ORGB, or in Spanish, Bagua. According to this technique, ORGB has not a terminal lateral anastomosis, but as a lateral anastomosis between the loop of the jejunum and the pouch. While the distance of the biliopancreatic trites from the biliopancreatic limb from the trites was at the beginning of their procedure, 2002, from 250 centimeters to 315 centimeters. But today, the authors changed their measurement of the small bowel, considering the technique of 60-40. So they measure the entire small bowel, and the biliopancreatic limb is 16% of the entire small bowel, while the common limb is 40%. You should consider that in the world, the majority of the authors adopt a mixed technique. So they don't adopt a pure MGB and they don't adopt a pure ORGB. So these are the terms searched in the 2080 position statement. And this was the data extraction. The operative technique. In the previous position statement, we saw that the literature gave us different description of the starting point of the gastric staple. At the same time, always in this position statement, we saw that there was a variation of the size of gastrojejunostrum. And at the end, also the limb length was different in the different studies that we analyzed. We can say that in 27 studies on 52 analyzed studies, we had a common limb of 200 centimeters, while only in 10 studies we had a tailored limb length. Then we had the problem of the name of the procedure, because in literature, the ORGB was called with the different names: MGB, ORGB, SAGB, OLGB. And most of them had not a connection with the pure MGB or with the pure ORGB that we analyzed before. This was the Prisma of 2018, where at the end of our analysis, we individuated 4 randomized control trials, 34 single-arm cohort studies, and 14 multiple-arm comparison cohort studies on MGB ORGB. So this was our tables of 52 studies. As you can see, we had 4 RCT, and we had 48 cohort studies, prospective or retrospective. So the risk of bias with these numbers here is high. Of course, in these tables, we could individuate that MGB ORGB was a safe procedure in terms of complication, was a safe procedure in terms of mortality, with a good weight loss, a good comorbidity remission, good operation time, a good hospital stays. But we had problem in terms of long-term complication. First of all, malnutrition. So, considering this position statement, what were the recommendations of the Ifso MGB ORGB task force? First of all, the name. In 2018, we decided the name was MGB ORGB. We talked about promising results in terms of weight loss and type 2 diabetes mellitus. Bile reflux was either underreported or didn't seem to be a major issue. Patients with revisional procedure of ORGB had results a little bit worse than the patient that were operated on of MGB ORGB as primary procedure. But very important thing was that MGB ORGB was a recognized bariatric metabolic procedure, and shouldn't not be considered investigation. This is what we wrote. At the end, we established that there was a paucity of RCT evidence, with the majority of evidence coming from retrospective cohort studies. This was the reason of the update of this year. It is published on obesity surgery of July 2021. So in this month, we have the publish of the paper. This position statement is issued and approved by Ifso Scientific Committee and Ifso Executive Board. This is the prisma that we have considered. As you can see, in this case, the electronic database were the same of the previous position statement, Cochrane, Embase, Medline, PubMed. But now we have a number of analyzed paper which is higher. We have 9 randomized control trials, 86 non-randomized quantitative cohort studies, and 50 reviews and meta-analysis of qualitative studies. Of course, the number of patients is always more than 50 for each studies to be considered, with a follow-up which is more than 12 months. We identified 4 tables. In the first tables, we identified studies with ORGB versus another procedure or standard-alone procedure. In table 2, the evaluation of long and short-term complications of ORGB compared or not with other surgical technique. In table 3, the technical details of ORGB, and in table 4, qualitative synthesis, review and meta-analysis. So in the first 3 tables, we considered a quantitative analysis of RCT and cohort studies, retrospective or prospective. While the 4th table is a table of a qualitative analysis, which can analyze only previous review or meta-analysis. Regarding the introduction of this new position statement, we wrote that ORGB appears extremely effective in reducing obesity-related comorbidities, offering a good quality of life with an acceptable complication rate. And then the increasing number of ORGB in Europe and Asia Pacific brought this technique in 3rd position in order of frequency behind sleeve gastrectomy and Roux-en-Y gastric bypass. If we go towards the tables, as we wrote before, in the quantitative analysis, in the study data, we have 9 RCT and not 4 as in the previous position statement. So we have been able to reduce the risk of bias. And in this quantitative analysis, we can see that this procedure has a good time of operation, so it's not very high. This procedure is a good hospital stay, low rate of peri-operative complications, and low rate of mortality. But if we consider long term complication, we have some consideration to do. Regarding bile reflux and regarding cancers, they don't seem to be major issues. But regarding malnutrition, it could be a main issue because of 2 things. One is related to the definition that the different authors give to the name malnutrition, and the other is the treatment that they do. The treatment of different kinds of malnutrition is not described in these papers. So going ahead, we can see that regarding surgical technique, we have an homogeneity in literature. While in the previous position statement, we could identify some differences regarding the gastric pouch and the gastrojejunal anastomosis. Now the literature is a little bit better, is a little bit more homogeneous regarding gastric pouch and gastrojejunal anastomosis. So this is a good consideration that we can do regarding surgical technique. At the end, the qualitative analysis. The qualitative analysis also suggests us that this operation has good results in terms of weight loss, comorbidities reduction, and perioperative complication. Good results, good regarding bile reflux and regarding cancer, but we have not clear ideas regarding malnutrition, also in the analysis of the qualitative studies. So what about the new recommendation of the Ifso ORGB task force? First of all, the name. ORGB should remain the official Ifso approved identifier for this procedure. MGB and ORGB are different operations for many authors, but both operations are similar because both operations have only one gastrojejunal anastomosis, and furthermore, most studies report on an operation that is not a pure MGB or a pure ORGB, but rather a mixed technique. We have learned from other procedures, Roux-en-Y gastric bypass, BPD, TS, that it's essential to define each type of operation under a single name. For this reason, Ifso selected the ORGB as the approved identifier for this procedure. Second, the outcomes from ORGB are promising in terms of short operative time, low operative complication rate, good weight loss, and good comorbidities remission, type 2 diabetes remission, hypertension, OSAS, and dyslipidemia. ORGB in the primary setting provides better weight loss and comorbidities reduction than in patients operated on ORGB as revisional procedure. At this stage, bile reflux does not seem to be a major issue for patients underwent to ORGB. And the same we can say for gastric cancer. To date, gastric cancer does not seem to be a major issue. Whilst the data is currently lacking, long-term nutritional deficiencies due to the malabsorptive nature of ORGB procedure should be considered. Long-term observational studies should be undertaken, potentially using national registries to better understand nutritional requirements. I have to say that this is a major issue related to this operation. I suggest the authors who want to publish regarding ORGB to identify the exact type of malnutrition and to identify and write the exact type of treatment that they perform. Because when then we go to do a meta-analysis or a systematic review where we analyze their papers, we have to be sure that we have talking with the same language. At the end, regarding recommendation, the majority of the studies included in this review are studies with less than 5 years follow-up. So we suggest the authors to do new studies and possibility RCT studies. I want to thank you again, Ifso, for the possibility that give me to do and to be the coordinator of the position statement and the possibility given to me to do this presentation. Thank you again.
Thank you very much, Mauricio. A very nice summary of this very important position statement. Manuela, can you please put the rest of multiple choice question? So second question, the unresolved issue is one anastomosis gastric bypass is the unacceptable high incidence of early postoperative complication, the high incidence of postoperative GERD, the high incidence of postoperative esophageal gastric cancer, and malnutrition. So please vote for which is unresolved issue with one anastomosis gastric bypass.
Okay.
Looks like the majority choose malnutrition. Let's go with second question, please. To second question, in one anastomosis gastric bypass, which is the following is directly related to malabsorption? The size of gastric pouch, the size of gastrogenostomy, the length of biliopancreatic limb, and the last one is the volume of gastric pouch. Well, 93% get it right. The length of the biliopancreatic limb is the single most important factor that affecting malabsorption. Let's go to the last question, please. So during one anastomosis gastric bypass, do you measure the entire small bowel selectively, routinely, or not at all? Looks like we have a split here. Some surgeons, yes, they measure it routinely, some they do selectively, and some not at all. So we'll discuss that later on. So let's next Dr. De Luca share with us his tips and tricks video about one anastomosis gastric bypass. Let's put Dr. De Luca video, please.
This video regards tricks and pitfalls of one anastomosis gastric bypass. As you can see, first of all, we have the necessity to perform a sleeved narrow gastric pouch. So we start with our incision at the crow foot or below 2 or 3 centimeters the crow foot. It's very important to have a distance from the gastroesophageal junction and our section of almost 18 or 20 centimeters. So we can find our first staple, which could be, as you know, a yellow line or a blue cartridge according to the thickness of the tissue. As you can see, we go towards the head of the patient, towards the angle of east. We don't start to take down the adhesion between the diaphragm and the gastric fundus, but we individuate them during our section. So in this step, we perform the detachment of the phrenogastric ligament in his anterior and his posterior sheath, and we perform the detachment of the mesogastrium. In the ORGP, an important trick is that we don't perform the distance from the esophagogastric junction and the fundus like in a sleeve gastrectomy, but we can leave a little bit larger gastric pouch in his superior part. This is very important in order to reduce the risk of fistula with this procedure. In fact, the fistula of the gastric pouch and the fistula of the gastrojejunal anastomosis in this operation is quite lower than in gastric bypass and in sleeve gastrectomy. The second step is to identify the biliopancreatic limb. If we perform a biliopancreatic limb of 115 centimeters or less, we don't need to measure the entire small bowel. But if we perform a biliopancreatic limb longer than 150 centimeters, we need to measure the entire small bowel. This is a lateral anastomosis. So this is a classic mixed procedure from the standard MGB and the standard ORGB, because we adopt a linear shelter in order to perform the anastomosis. And then we close the anastomosis with a barbed shelter. As you can see, in this case, we have performed a biopsy of the fourth segment of the liver, because if we have a suspect of a NASH or every kind of steatohepatitis, we perform it considering that this is a procedure which has a malabsorption. We are at the end of our anastomosis, and after this step, we perform a methylene blue test for a double reason. First reason is to individuate a possible leak of the gastric pouch and of the gastrojejunal anastomosis. Second reason is to individuate on the left part, right part of our screen, also if there is a good continuity with the biliopancreatic limb. At the end of the procedure, we perform some jejunal gastric stitches as anti-reflux stitches, and of the efferent limb, we perform other 1 or 2 stitches in order to give a good orientation to the common limb. Usually, in order to reduce the hemorrhage, but first of all, in order to reduce the torsion of the gastric pouch, we adopt some glue. If we fix the omentum to the gastric pouch, we reduce the possibility of torsion. This is the end of the single anastomosis, and this is the external part of the body where we don't use nasogastric tube and we don't use any drainage. Thank you.
Okay, you hear me now? All right. So there is a couple of questions. One from Dr. Jack Hempis. This for Mauricio. He noted
Yes,
that.
do you hear me?
Yes,
Alan,
yeah, I hear you, Mauricio. There is a question for you, Mauricio, from Dr. Jack Hempis. He noticed in your presentation that Ritz Tovar publication were mentioned 3 times at least, and he mentioned that some some issue about the scientific accuracy of this publication, and it was withdrawn from surgical endoscopy. Do you have any comment about that?
Yes, I agree with him. In fact, in our last update, we removed the papers of Ruiz Tovar. So we have not in our systematic review the papers of Tovar.
All right. Then we have another comment from Dr. Ashraf Haddad. He said, if worldwide, one anastomosis gastric bypass survey have a clear description of surgical management and trend of malnutrition after one anastomosis gastric bypass.
The issue of the malnutrition is the main issue of the RGB. This is what we reveal in this systematic review. This is a true issue. He's right. I agree with him. But the main problem, the main problem is that the authors don't describe exactly what they mean for malnutrition. In the mind of some author, malnutrition is hypovitaminosis, while in the mind of some authors, malnutrition is only hypoalbuminemia. And they usually don't write what is the treatment that they perform. The treatment is, of course, different related to the different kind of malnutrition. So what I suggest to the surgeon who publish regarding ORGB is to be homogeneous in the description of malnutrition, because malnutrition is a clinical problem that has a right, exact description.
Then you have 2 comments, one from Dr. Mary Kani about vitamin deficiency. We're going to discuss that. And one from Dr. Bashir regarding the factor can contribute to malnutrition. He mentioned that the volume and the size of the pouch, as well as the periopancreatic limb length, are important factors. So let's get started with the discussion. We're going to divide the discussion into pre-op, intra-op, and post-op. So let me ask Mark. Both Mark and Maurizio, you guys doing one anastomosis gastric bypass as well as 2-in-1 gastric bypass. So how you decide which patient get what? So if you have a patient coming to you, ask for gastric bypass, how you decide this patient need Roux-en-Y gastric bypass or anastomosis gastric bypass? Let's start with Mark.
Oh, well, in Paris, we have been studying the one anastomosis bypass for 15 years. So that's why we've been doing more one anastomosis than Roux-en-Y. But I think the question, the essential question is, well, reflux and malnutrition. We've seen that. About the reflux, we have done experimental studies in rats. We have created the rat model of one anastomosis, and we have published. We kept the rats during 16 weeks, and we did histological and molecular analysis, and we didn't see any significant increase in the PCR of the genes of interest, the genes of the Barrett's ulcer markers and the esogastric carcinogenic markers after 16 weeks. So that's the first answer to the question of the potential risk of the reflux. The second answer to this question about the reflux has just published today in the obesity journal issue. It's our last article. We have studied the reflux after one anastomosis, and we saw after pH and impedensometry that most of the reflux is not bile reflux but acid reflux. And that's what we thought clinically, because most of the time when a patient after one anastomosis has reflux, we gave them PPI treatment and it worked. So that's now confirmed by this pH impedensometry that most of the reflux is not bile reflux and acid reflux. And that's the main reason why we do not consider the reflux as a main concern with the one anastomosis.
All right, so question for Mauricio. So which patient that you don't give one anastomosis gastric bypass? So which patient in your practice that you can tell him or her that I'm sorry, I cannot do one anastomosis gastric bypass on you?
Alan, excuse me, Alan.
Yes,
you hear me?
I hear you. Yes. So
okay, I had one problem of connection. So the question is, when I don't perform one anastomosis gastric bypass, in which patient?
Yes. Yes.
Okay, of course, I try to avoid this operation in young patients, young women, because I had some not good experiences with some women during pregnancies. So I advise them of the potential malnutrition during pregnancy. The second is when I have a patient with a high symptoms of reflux or esophagitis grade C of Lyon. So if I have patient with high grade of esophagitis or clear symptoms of reflux, I prefer a Roux-en-Y gastric bypass. Third situation is when I have a patient with an history of alcohol abuse or a situation of advanced NASH. In this case, I prefer a sleeve gastrectomy.
Good, thank you. Mark, do you do routine preoperative endoscopy?
Yes, routinely, always.
Okay.
I think it's mandatory.
Me too.
Thank you. Okay, very good. Let's go to technical question. Mark, how you construct your pouch? And does the pouch volume affect malnutrition?
Well, in my experience, I don't think the pouch size can cope. It has to be calibrated on a 36 French bougie. Well, it's long and narrow, but it must be sufficient. It is not, in my experience, a cause for malnutrition, because it's a principle. The pouch of the size, the size of the pouch is the principal reason. On the contrary, on weight regain. In our experience, when there is weight regain after one anastomosis, most of the time it's because of dilatation of the pouch. So it's on the contrary, it's not malnutrition, it's weight regain.
All right. And what about you, Mauricio? How you construct your pouch? You showed that you're doing a long, narrow pouch. Any other thing you want to add about construction of the pouch?
No, I think that the pouch has to be as minimum 20 centimeters from the esophageal gastric junction, and it has to be narrow, I agree, not very narrow at the esophageal gastric junction, like the sleeve gastrectomy, in order to reduce the fistula of that side. And in my experience, I don't see any correlation between the pouch size and the malnutrition.
All right. What about the gastrogenostomy? Mark, how you construct your gastrogenostomy in the term of the size and orientation?
Quite like Maurizio showed us, but I use a 45 millimeter linear stapler, and I put it on the posterior surface perpendicular to the horizontal stapling. So that I think well, it can avoid some reflux like that, because the afferent limb is backwards and the efferent limb is in the front. So it's perpendicular to the horizontal stapling on the posterior surface.
And how big is the staples we use for anastomosis?
How big is it? Well, it's 45 millimeter long, so it's not very narrow. I don't think it's necessary to do it narrow. It's normal size, 45. 60 could be dangerous, because the horizontal stapling could be too much high, but 60 is not necessary. 45 is okay.
So this is another difference between raw gastric bypass and one anastomosis gastric bypass. So on raw gastric bypass, we try to make the gastrogenostomy small, but here in one anastomosis gastric bypass, it's wide. And I think the reason behind the wide that you do believe that rapid transit of food into terminal ileum will increase the secretion of GLP-1, which all the benefit of GLP-1 for diabetes and for weight loss. Is this correct, Mark?
Well, I don't know the answer exactly. What I can see is that the remission of the diabetes after one anastomosis is very high. Remission rate is more than 80% after 2 years in our experience. So,
okay.
And
yeah, okay. We have question about the biliopancreatic clamp. Yeah, we cannot overemphasize the metabolic effect of biliopancreatic clamp. So maybe Mauricio and Mark, do you measure the biliopancreatic lamp? You do a fixed length, or you measure the entire small bowel?
In my experience, when I have a patient with a class 2 obesity, for example, so he has or she has not a very high BMI, my biliopancreatic limb is 150, and in this case, I don't measure the entire small bowel. But if I have a patient with an higher BMI, or is a reoperation after a failure, for example, of a gastric banding or a sleeve gastrectomy, in this case, the biliopancreatic limb needs to be longer, I measure the entire small bowel. I want to remember two things. There are some papers who try to correlate the small bowel length to different parameters. What we know today is that we can compare the length of the small bowel only to the height of the patient. we cannot have an idea of the length of the small bowel regarding age, regarding race, regarding BMI. This is very important to remember. Second, we can have a small bowel, a medium length of 6 meters, 70 centimeters. This is the medium. But we can have small bowel with a length of 3 meters and 50, and small bowels with a length of 11 meters. So it's necessary to know the length of the small bowel. In conclusion, in my opinion, also only if you want to perform a very short, small biliopancreatic limb, you don't need to measure the entire small bowel. In the remnant of the cases, you have to measure the entire small bowel.
So your comment, at least selectively, you measure the entire small bowel if you are planning to do biliopancreatic limb more than 150.
Yes.
What about you, Mark? Do you measure the entire small bowel?
Historically, the regular one anastomosis described by Robert Routledge have a BP limb of 2 meters. That's how we began some years ago. And with 2 meters, we found that there was some nutritional deficiency. And it has been recently confirmed in the French national randomized trial called E-Omega, which compared 2 meter BP limb with Roux-en-Y and showed that there were some nutritional deficiencies. So since 5 years, we decided to bypass only 1 meter 50, but not measure the total limb length, because one of the advantages of the one anastomosis is that it should be a quick and easy surgery. And if you measure the total limb length, the measurement can have its own morbidity and the operation will last longer. So we decided just to measure 1 meter and 50. And we found the same results if the preoperative BMI is under 50. And I can tell you that in France, we have decided this year to do a new national randomized trial, but not with a 2 meter limb, but with a 1 meter 50 BP limb, because really it looks like 2 meter can be dangerous in some very special cases, as Maurizio told us.
All right, let's move to Peterson space. Do you close Peterson space, yes or no? And if you close it, how you close it? Let's start with Mark. Do you close Peterson space when you do one anastomosis gastric bypass?
No. Well, the advantage of the one anastomosis is that there is no mesenteric defect. And in our experience, the internal hernia through the Peterson space is very rare. I know it can occur, but it occurs, as far as I know, in patients who have lost quickly a lot of weight, and it's still so rare that I didn't find necessary to close this Peterson space.
What about you, Mauricio? Do you close the Peterson space routinely? Mauricio, are you there?
I don't.
You don't, yeah, because it seemed to me Peterson space with Roux-en-Y seemed like Peterson space with one anastomotic gastric bypass. You know, and the risk of internal hernia is lifelong. The more we're losing weight, the more the space can open more. And diagnose sometimes is challenging, you know, and this is a risk for, you know, for a dead bowel. So in Roux-en-Y gastric bypass, I do close all the spaces, include Peterson space. One more question about hiatal dissection. Let's start with Mark. Do you do routine hiatal dissection or selective? And if selective, when you do it?
Well, it's rarely necessary to dissect the hiatus. We always do an upper GI X-ray, so we know if there is a huge hiatal hernia. But if not, we did not find it necessary. As I told before, the reflux is not such a concern that we need to do it.
What about you, Mauricio? Do you dissect the hiatus routinely or selectively, or not at all?
Only selectively when we have an RX swallow who suggests us the presence of a hiatal hernia. I want to give two small tricks to our audience. One regarding the problem of the hiatal hernia. If we have a reflux with OHB, the reflux in the majority of the cases is not related to a problem of hiatus, but is related to the acid biliary reflux coming from the biliopancreatic limb and the reducted passage of the food in the common limb. So this is the main reason of this the reflux. Then I want, if you give me 30 seconds, I want to give another trick to the surgeon regarding the small bowel measurement, because many surgeons refuse to do it because they have to change their position they have to go on the left side of the patient and to start with the measurement. It is not true. You can do in another manner. After you have measured your biliopancreatic limb, you can go ahead in the same position of the surgeon. You can go ahead from cephalic to caudal for other 250 centimeters or 300 centimeters. You don't need to reach the iliosacral valve. If you measure, for example, 2 meters of your biliopancreatic limb, and after that 3 meters of after this your biliopancreatic limb going from cephalic to caudal in the same position, you can go ahead, and you don't change your position. So you employ only 4 or 5 minutes to do that.
All right, we have a couple of questions about post-operative care. Do you do, Mark and Mauricio, do you do routine post-operative endoscopy as surveillance? This is what Ifso recommend because the concern of bireflux and the risk for cancer of the esophagus. Ifso recommend routine surveillance. Do you do that, Mark? Mark, you do?
Well, we've learned with experience that
Mark,
post-operative endoscopy was mandatory after sleeve gastrectomy. Why not do it with the one anastomosis in order to be sure? We have some acid or bile reflux, so we need to survey it, and it's now officially recommended.
What about you, Mauricio? You do routine post-operative EGD? Mauricio, are you there?
Routinely after 3 years, and if we have some suggestive symptoms, also before.
Dr. Jack Hemphiss has question about reflux after one anastomosis gastric bypass versus reflux after row and Y gastric bypass. So, Mark, do you see any difference in the term of kind of reflux, incident of reflux after one anastomosis versus row and Y gastric bypass?
I'm not able to answer because I have not compared Roux-en-Y to one anastomosis. So what we have done is out of the 1,650 first patients, we have 43 cases of genuine reflux, and we have studied then by pH metry and impedance metry, and you can see in the article which is published today on the issue of July that most of them are acid reflux and the other bile. So, but I cannot say in comparison with the Roux-en-Y.
There is a question about how you manage post-operative diarrhea or steatorrhea after one anastomosis gastric bypass. Mauricio, can you take this question?
Yes, we have a few cases of important diarrhea. We mean more than 4 stools per day for diarrhea. While quite often we have steatorrhea, but it is a mild steatorrhea. In any case, this is an issue, and we have to share it with the patient before.
Yeah, we have a question. Jack Hanfes, he's talking about the difference between 150 and 200 centimeter biliopancreatic clamp is very critical, and it may depend on the technique of measuring the bowel. You stretch the bowel, you put the tape inside. How you measure your bowel? What method do you use of measuring bowel? Mark?
Marking of Grasper. No,
Marking
essentially
Grasper.
Grasper with 5 centimeter each. Yes.
What about you, Mauricio? How you measure the bowel?
Mild stretching with Grasper.
Grasper. Okay. Some question about bireflux to Mark. So you talked to us about your study, your recent study, that you saw more acid reflux than bireflux after one anastomosis gastric bypass, and also there is some study about scintigraphy that the bile does not reach the esophagus, which give us a peace of mind regarding bireflux and the effect on the esophageal mucosa. Then regarding tips and tricks to decrease bireflux, Mauricio, you talk about anti-reflux. Can you tell us more about this stitch? Where you put the stitch?
Okay. Alan, do you hear me? Allora, regarding the stitch, yes, regarding the stitch, they are created by the original operation of Bagua or OAGB of Carbaco. They applied some stitches between the biliopancreatic limb and the gastric remnant, and some stitches between the biliopancreatic limb and the gastric pouch, in order to have a different position of the biliopancreatic limb. Of course, this is true when the patient is in a erect position, but when the patient is in a supine position, when he is declined, these stitches are not good. They are not useful. In any case, I see that these stitches can give in help, so I adopt them.
All right. So regarding management of bireflux, so if somebody come with some green saliva coming from his mouth, you think maybe this patient has acid, bireflux, and you can document that with EGD or with scintigraphy. How you manage this patient, Mark? How you manage a patient with bireflux?
We must confess that it can happen. We have a 2 to 3% rate of bile reflux, which are intractable bile reflux. They occur 2 or 3 years after the one anastomosis in patients who have lost all their excess weight. And they are so intractable that they need to be reoperated in that case, but 2 to 3%. And in that case, it's necessary to convert them into a Roux-en-Y bypass, yes. But it's still, in our experience, a low rate of 2 to 3%, a very special cohort of patients who suffered 2 or 3 years after the surgery, and they have lost all their excess weight. And you give them PPI, and it doesn't work in that case. So they need to be reoperated.
Another question from Dr. Hempis regarding the anti-obstruction or anti-reflux stitch. Maybe I'll give you to Mark, you can answer that. He said sometimes this stitch can be causing obstruction of the afferent limb. How do you avoid that? How do you avoid afferent limb obstruction from putting this anti-reflux stitch? Mark?
Well, I just put one stitch on the upper part of the limb, just in front of the anastomosis, just to avoid tension on the anastomosis, but it cannot cause any obstruction. It's just an anti-tension stitch.
Okay, all right. We have a question regarding supplement. Post-operative patient, what supplement, vitamins, micronutrient, and macronutrient supplement you recommend, and how you manage vitamin deficiency? Mauricio?
Okay, we give some standard supplementation in our in Italy. We have some drugs that consider the supplementation of the ISMBS 2012. So we give the standard supplementation that we gave in the past for malabsorptive procedure, biliopancreatic procedure, for example. Then, of course, this supplementation can vary after 1 year or 18 months in according with the malnutrition, the state of malnutrition of the patient, in according with his steatorrhea, in according with his or her eventual diarrhea, but first of all, in according with his food intake. If we have a patient who has a correct intake of correct food, we can reduce the supplementation. But if we have patient who eats only food without proteins or vitamins, we go ahead with the supplementation. What in case of hypovitaminuria? We give the specific supplementation of that specific vitamin, of course.
There is a question from Dr. Mary Okani regarding the degree of malabsorption, vitamin deficiency, and your supplement and the monitoring. In other words, if you do a long length, more than 150 milligrams, do you give extra vitamins? Do you monitor the patient more frequent? Mark? So the question, if you do a longer than 150 and you have vitamin deficiency, how you manage this patient? Do you give more supplements than than the standard 150 centimeter peripancreatic lamp? Do you bring the patient more frequent?
It's like the experience we had with the biliopancreatic diversion. I mean, if the bipilim is longer than two meters, this patient should be considered as potentially with the risk of malnutrition, and they have to be really correctly followed. But in my experience, the most important problems we have with the vitamins is iron. Is still iron in young women because they stop taking the iron. It's the rest of the vitamin is not such a big deal with one anastomosis.
All right. So I think we don't have any more questions. And I would like to conclude that one anastomosis gastric bypass is definitely safe and effective, and we have more and more data to back up our our comfort regarding the bireflux and the risk of cancer. And the only issue that we'd like to work on is the malabsorption, and it's mainly related to the length of biliopancreatic limb. So we should have good position for our one anastomosis gastric bypass in the armamentarium of management of obese patient. The only think that we need more and more long-term data. I would like to thank Ifso for the opportunity, and any Mark or Mauricio, you want to add anything, a last word for the audience?
Regarding me, first of all, I also want to thank you to everyone, but I want to give the last suggestion to the surgeons who are listening us. Do you hear me? Do you hear me?
Yeah, we hear you, Mauricio.
Okay, but the suggestion that I want to give, they have regarding the malabsorption, which is the main problem of this procedure, they have to be clear what they want to do with that specific patient. If they have a like patients with a low class of obesity, of course they can perform a biliopancreatic limb of 115 and they haven't a problem of malnutrition. But if they perform a reduced surgery or patient with high BMI or patient with a low compliance and they want to do a higher biliopancreatic limb in terms of centimeters, they have to be ready to consider the possibility of malabsorption. So they have to be able to interpret it and to treat it adequately.
All right, Mark, how you see the future of one anastomosis gastric bypass? You spend most of your career studying this.
So in France, we are very happy to be able to do this randomized trial comparing 1.50 m to Roux-en-Y, because now the one anastomosis is no longer reimbursed for a stupid political reason that in 2019, France was the third country in the number of bariatric procedures in the world after United States and Brazil. And as it's completely reimbursed, it costed too much to the health. So that in spite of giving a new codification, they decided not to reimburse it. But in the future, I'm sure it will be much better because it's the third procedure done in bariatric procedures, and this randomized trial, I think, will allow us to work normally as the other countries. So
Great.
Future will be good.
Great, thank you very much. I would like to thank you, the audience, for the attendance of this very important webinar, the discussion. I thank you the panelists and the presenter, and also special thank to Manuela for help for this event. Thank you very much. Thank you.
Thank you. Thank you.
Thank you. Bye.
You.